Good afternoon, everybody. I'm going to give it just about one more minute for everybody to make sure they can join and get connected, and then we'll get started in about 60 seconds. All right, everybody. Good afternoon and welcome to today's webinar titled The Best Defense is a Good Offense. Also, if you check out the events section of the Georgia HFMA chapter's website, you will see that we publish all activities from Georgia HFMA, also other chapters in our region as well. I do encourage you to take advantage of the education sessions offered not only at our chapter level, but for the Region 5 level as well. Region 5 is Georgia, South Carolina, Florida, Tennessee, and Alabama HFMA. My name is Matt Fisher, and I'm on the board of directors for the Georgia chapter of HFMA over webinars and forums. Quickly, I'm going to roll through some housekeeping items, and then we'll get started. All phone lines will be on mute to avoid interruptions during the broadcast. Please submit your questions via the Q&A or questions box at any time. We'll keep track of those and allow time at the end for Q&A. I'll coordinate with our presenters for their answers at the end of the presentation. You'll receive the presentation recording and other links for a survey, also CPE credit form within 48 hours via email from me. And also everyone on today's call is eligible to receive continuing education credits for participating. This session is hosted by the Georgia chapter of HFMA, so we'll follow our chapter's process on issuing continuing education credits. Please be on the lookout for that info from me coming on Friday as well. Now I'd like to take a second to recognize and thank the Georgia chapter sponsors, whose logos you can see on the screen now. We certainly appreciate all of your support. And then lastly, I'm going to introduce today's speaker for the session, Jeremy Shaw, Assistant Vice President of Revenue Cycle at HBCS. Jeremy Shaw is an experienced Assistant Vice President for HBCS with a demonstrated history of working in the healthcare industry with a focus on revenue cycle. He is skilled in data analytics, change management, and leadership. Jeremy is a strong professional and got his Bachelor of Science in Business Administration degree from the University of North Carolina at Chapel Hill. Jeremy, we're ready to go.
Great, thanks, Matt, and thank you for that introduction. Before we jump right in, I just wanted to quickly go over HBCS at a glance, just so everyone is aware of who we are and sort of what our role is in the healthcare space. We are a revenue cycle management firm, primarily focused on insurance and self-pay billing and follow-up, and we'll talk about a little bit today, but more recently, we have also expanded our service offering to include patient registration functions. So we've been in business for about 35 years, exclusively servicing the healthcare industry. Prior to the pandemic, we had 3 CBOs, 2 located in Delaware and 1 in Massachusetts, as well as a virtual environment. However, since March, we are 100% remote, and will continue to be so for the time being. At the earliest would be July that we would potentially have some staff return to the office, but things have been going very well remotely, so don't want to disrupt that until we get the pandemic under control and vaccinations ramped up. We do have a heavy investment in not only talent management, but also technology and analytics, always trying to stay ahead of the curve and make sure that we are making revenue cycle process as seamless as possible and as efficient as possible, really. And then the bottom box is just give you some idea of our scope and size. So approximately 500 revenue cycle professionals, 5.2 million accounts processed annually, which equates to about $5 billion in charges that are placed with HBCS, and then that converts to roughly $3 billion in reimbursement that we collect for our healthcare organizations. In terms of today's agenda, our discussion is really about ways to deploy a proactive revenue cycle strategy to defend against lost revenue, not only in the middle of this pandemic, on the back end of the pandemic, but really as we go into the future and think about ways to just maximize reimbursement and shore up our revenue cycle for future pandemics. I think The halt to elective procedures certainly caught a lot of us off guard, and no one really thought there would be a pandemic where hospitals, in some cases, were empty, which was a good thing. But we all know it had a significant financial impact for all of us. So a lot of what we discussed today may not be groundbreaking or new, but more of a back to the basics mentality, and making sure that we are taking the time and energy to shore up any gaps we may have in our revenue cycle. So the four main parts we wanted to talk about was, one, implementing COVID-19 best practices and customer service enhancements. Right now, again, as we're moving towards the back half of this, really focused on testing and the vaccination plan, and making sure that we tie that to the registration process, that second bullet there. How do we make sure we prevent lost revenue through just simple adjustments to the registration process? And then number three, leveraging analytics and workflow technology to simplify denial management, and really taking a holistic approach to billing and follow-up, and making sure that we are prioritizing accounts appropriately, and working smarter, not harder, to collect on the outstanding balances. And then lastly, just making it easier for patients to pay. So not only easier for patients to pay, but also just improving our communication with our patients, especially now, has certainly been critical, more than ever. And before we dive right in, the first polling question: how much has COVID-19 impacted your revenue cycle process? Very few changes, some changes, many changes, or significant changes. And typically we do see a mixed response here, but I don't know that we've ever seen someone that had very few changes after coming out of the pandemic. So. All right, so the results are in. As expected, most of us have seen many changes, some significant changes, but again, no one really in that very few changes aspect. There's certainly been a lot of moving parts with this, and we were all sort of learning as we go. So very much what we would expect to see. So first up is focusing on customer service. On the previous slide, I talked about refining the testing journey and ways to support vaccine administration. And we've done this presentation with a number of HFMA groups, and it continues to evolve as we get further down both the testing and vaccination route. I think the big thing to be mindful of, and we'll go in more detail in the registration process, is that testing and vaccination has now created new entry points into all of our organizations. And not only that, but the patient churn and the amount of appointments that we're seeing with regard to testing and vaccination is really unprecedented to what we were used to. So with that, there's been a lot of pressure on our registration and our front-end processes. And we'll talk a little bit more about how to make some tweaks on the registration side to make sure that we aren't loosening our registration standards, because it is critical, as we all know, to maximizing that reimbursement. Secondly, if you're not already, this guarantor-based customer service resolution has been around for a while, and it's been talked about. If you haven't implemented it already, now is certainly a time to start exploring and trying to do that where possible. COVID-19 has certainly increased, and maybe more than ever have we seen large amounts of households getting care at the same time, because of just the sheer fact of, if one person has been exposed to the virus, they're typically going to a testing site with all of their household. And in order to reduce confusion, streamline patient communication, if you're sending one statement to that head of household or that head guarantor, it's going to be a lot more easier for them to digest and pay that bill, as opposed to getting 6 different statements, depending how many people they have in their household. Not only that, but certainly a huge cost savings on the expense side for an organization, with just mailing costs, statement costs, and consolidated billing efforts. The next piece, right in line with that patient approach and customer service, is flexible patient messaging across channels, and making sure that we don't just have a one-size-fits-all approach to communicating with our patients. Most of us digest our information in very different ways today. Some prefer to receive a text message and get a bill and go online and pay it. Others still like to receive that hard copy bill and pick up the phone and call someone. So making sure that we have multiple ways to communicate with our patients not only increase the likelihood that we'll get in touch with them or have them see our communication, but also just increase the likelihood that they'll respond positively to that and fulfill their financial obligation as well. And then lastly, more just on the investment in our people, is continuous QAR and feedback. So leveraging speech analytics, call recording, screen capture to the extent that you're able to just have a better understanding of what our patients are calling in for, what are the particular pain points that patients are reaching out to us to get further clarification on. That way we can train our staff and have them better prepared to handle these situations. Obviously, I think patient anxiety is at an all-time high as well. People are confused, they're nervous, whether or not they're getting a positive diagnosis or a negative test result. There's still a lot of unknowns, and what does this mean for as far as my financial liability, what's covered, what's not. So continuous QAR and feedback and having a close ear to the ground on what's being said out on the contact center floor is certainly critical. So refresh registration and scheduling. Again, the registration process has been around forever, and it's pretty straightforward. However, when testing was getting stood up, I think, a lot of us took the approach of let's not let perfect get in the way of something good. And, we may have had some long wait times at testing sites or some long handle times, but it is critical. As I mentioned, this is a new entry point into the healthcare organization. A lot of the patients getting tested have never been to a hospital in their life. And so it certainly is critical that we get their proper insurance information and have them registered ahead of their visit. And so now that we are, what we're seeing a lot with some of our partner clients is that quickly testing sites are now transitioning into vaccination sites, or at least preparing for that. So testing may start to decrease, but vaccinations will be right there, and that patient churn will certainly still exist. So it's never too late to really reevaluate that process and bring on additional resources or put an extra emphasis on that. I mean, it's critical that revenue cycle have a seat at that table when those decisions are being made as to, how we're going to accept testing and how we're going to accept vaccination registration. So just continue to invest. And a lot of times we've seen that just the normal registration teams can't handle the volume. So number of different options out there, whether it be bringing on temporary resources. Hopefully this isn't around in 6 to 12 months from now. So we may not need to add actual FTEs to our budget, but it may make sense to partner with a staffing agency and bring on some temporary resources, or focus on, a short-term partnership to make sure that we are handling those calls and getting patients registered accurately. So now as we move out of registration and more to the back end analytics and workflow automation, one of the things that we always emphasize is starting with an exception-based workflow and allowing technology to drive the accounts to the right people at the right time. We are always big on that. Our staff are not the process experts. They're the subject matter experts. So we're really doing them a disservice when we don't have a clear workflow that drives accounts to them. And instead, we rely upon them to figure out which accounts to work and which ones take precedence. So a couple of the ways that we have found to be very effective in the exception-based workflow world is 835 denial routing. So using the data we're getting from our 835s and driving different denials to different representatives based on a particular skill set, as well as bringing it due for follow-up immediately. If it billed out and now all of a sudden you get a denial at day 20, making sure it's not waiting around till day 30 until it hits someone's radar, but triggering that immediate follow-up action automatically. And then sort of the flip side of that is automated claim status, where the whole goal is really touch avoidance. How do we use the data that we're getting back from payers to, whether it be penned accounts out that we see have hit the payment floor or have a pending payment and we're just waiting for cash posting to receive it and post it. There really is no benefit to having an actual FTE touch that. So how do we use that automated claim status? And if we do get that claims pending or claim is pending payment, extend that out a little bit further in the follow-up cycle so it doesn't hit a representative's work queue, and allow it to pay cleanly and avoid that unnecessary touch. And then lastly, wherever possible, utilizing bot technology or macro automation to replace some rote tasks. So claim status is certainly part of that, but if there are some particular rote tasks that can be replaced with simple macros, maybe be updating an account note or putting a different status on an account based on a response we get from a payer, are all certainly things that can help reduce the unnecessary touches. And as we move to the right, we're talking about account prioritization and reimbursement methodology. So once we have the exception-based workflow in place, and now we have the pool of accounts that need to be worked by our FTEs, how do we then sort that list in a meaningful way that's going to allow us to maximize revenue? Tried and true method is always a combination of balance and or age. A lot of places just alternate between the two to make sure they're covering the high dollar accounts, but then also keeping an eye on their aging to make sure that doesn't get out of control and further harm reimbursement. And really what we've done is developed an insurance score that combines these two factors, as well as things like denial type and client-specific statuses that mean something for an account, to create a unique insurance score. So as we dig into the denial piece, we'll know that certain denials have a higher likelihood to be overturned than others. So how do we factor that into our scoring? Because all accounts with a $10,000 balance are not the same, and they're not at the same point in that collection cycle. So how do we use more than just age and balance to really better predict the likely financial outcome of that account, and then in turn make our staff work more effectively and more efficiently to recover those dollars? And then as we move to the bottom, the skilled and knowledgeable team, we can have the best technology in the world and really the best workflow, but if we don't have the right driver of those vehicles, it's going to crash every time. So we cannot forget the people aspect of things. We have to continue to recruit well, train, and have that QAR and continuous feedback loop in place to make sure that the staff are maximizing that technology to the best of their ability. I always say there's two ways to really implement technology. You can either turn it on or you can embed it in your workflow. And a lot of organizations, buy technology off the shelf and are in a rush to just turn it on. For example, claim status. And you could be using the claim status you're getting back, but if it's not tied to the way the representatives work those accounts, then you're not getting any ROI on that, because the two aren't talking to each other and they're not working together in a consolidated workflow. So making sure your staff are fully aware of the intended workflow and that the technology that you're implementing is embedded in that workflow, keeping the staff at the forefront is critical. And then the last pillar here is denial analytics. I talked a little bit about it on the insurance score piece, but wherever possible, having specialty appeal and collection teams based on denial type. Now, certainly, if it's a smaller team, you don't really want to be that segregated. But if you have a larger team, the more specialized you can get, the more successful that user is going to get at working specific denial types, or it may just suit their skill set better. So wherever possible, that certainly helps. Denial trending by CARC payer provider, making sure that there is helpful denial analytics in place to highlight the problems so then we can fix them both upstream and in the follow-up process to really get at that root cause analysis and prevention. So our next poll question, how would you rate your denial analytics and reporting? Excellent, good, or needs improvement? Certainly getting some mixed responses on this one. Again, sort of to be expected. Just give it another few seconds. All right, so looks like the majority of us are in the good, fall in the good category. Quite a few needs improvement, and then some excellent as well. So that's great to see. So as we move forward to a little bit deeper dive into denial analytics and root cause analysis, I wanted to talk about some of our denial segmentation and ways that we've been successful in not only prioritizing our denials on the back end, but also using it in our reporting to drive improvement. So we segment all of our denials, well, all of denials in general, into 4 categories, which you see that A, B, C, D quadrant there. Category A would represent denials that have a high preventability upstream. However, once the denial hits, very low likelihood of collecting on that or overturning that denial. For instance, if there's no authorization on file, we can prevent that upstream, but if it requires an authorization and we don't have it backstream, you're not going to have a high success rate. Category B, high preventability, but also a high likelihood of overturning that. So this could be COB issues where we didn't have the right insurance up front, but we can still get that corrected and paid appropriately. Category C is more of the info-only denials, can't really prevent them, not really a lot of collectability in there. So it's bundling, capitation, things of that nature. And then segment D would be more of your pay or stall tactics. So very low preventability. However, if you do the necessary appeal and provide the necessary documentation, you do have a high success rate overturning those. A lot like medical record requests, most will not let us send them up front. However, once we do send them, once requested, very high success rate. So we take a look at those 4 segments, and through industry trends and our nationwide database, really, we establish a baseline for each and every 360 some odd CARCs to define what is an appropriate or expected overturn rate once a denial hits. For instance, medical records, if we think that most of the time that should be overturned at an 80% rate, we're looking for member organizations to hit that 80% or higher rate. If there's a particular CARC that we are overturning less than the expected overturn rate, that's where they would fall into the back half in that E, F, G, and H segments to create 8 segments. And so E, F, G, and H would represent the segments where we have an opportunity to improve and capture more revenue by increasing our overturn rate in those segments. And again, all of the overturn rates are factored into the way that we're following up on accounts so that we are prioritizing those medical record requests over, the info-only bundling type denials to maximize reimbursement on that front. So part of the denial reporting to help annualize that target improvement number is we take a look at everything, all of the CARCs that fell into the E, F, and G segments. H would be that one that really doesn't have any financial viability. But we look at E, F, G, and H. If we improve all of those overturn rates to the expected overturn rate, we can calculate a net improvement opportunity that's available for any particular healthcare organization. In this case, this sample would be roughly a $16.6 million opportunity just by improving the overturn rate. The one thing that this report doesn't capture is that in segments A, B, C, and D, particularly A, that high preventability segment, even though we may be overturning at the expected rate, how do we prevent them altogether and speed up that cash and accelerate those cash collections and reduce the cost to collect from the manual efforts on the back end. So this is just one way that we are using the denial analytics to not only highlight, volume and types of denials, but also where we're underperforming from a billing and follow-up standpoint. Our next poll question: how much change have you seen in managing patient payment? Very few changes, some changes, many significant. So based on the results, looks like most of us are falling into that some changes category. Just one in the very few changes, and then 6 and 4 in the many insignificant changes. This is certainly one that continues to evolve as we move forward. This survey that we have here was conducted in September, and it looks at changes implemented in collection strategies due to COVID-19. And the types of changes. So as you look to the bottom, you can see the two biggest ones that, north of 40% of organizations said that they delayed bad debt placements and or allowed patients to take 1 or more months off from payment plan. So from the very beginning of COVID-19, these were popular things to do, not only in the healthcare industry, but the entire financial industry and loan industry, is to have that payment forgiveness. And, the healthcare providers were certainly no exception to that. The one that I thought was interesting was that in September, you had very few implemented new vendors or technology. I think that's to be expected in September because it was, again, trial by fire, and everyone was worried about, how do we service our patients? The last thing anyone was going to take during COVID-19 was going to be a new technology implementation. But I think it uncovered some issues in all of our revenue cycle processes. And now as we move forward, I expect that this survey were conducted 6 to 12 months from now, implemented new vendor or technology will have a much higher participation rate, just because as the dust settles, it's much more clear where we need to focus our time and energy to be more efficient in the future. So the last topic is the digital patient experience. And we talked about in the beginning, not only just making it easier for patients to pay, but making it easier for them to get their information. And it's important that all of these talk to each other. So starting out with digital and print communications, having text options available, paper statements, of course, are not going away, and then e-notifications, so emailed receipts, email payment plan reminders, things of that nature. All of this increases the likelihood of reimbursement when we have various options for patients to opt into or opt out of their preferred method of communication. And then secondly, once they get their information and they understand it, making sure we have payment sources that meet their needs and their preferences. So obviously online web portal is a huge one. Calling and paying over the phone is still very big. Specialists answering the phone, most of the time patients have questions about their bill. They want to make sure they understand it, and then they give their payment to that representative over the phone. Lockbox, of course, certainly has a high adoption rate. People are uneasy sharing their credit card information. They prefer to just to write a check and send it in the mail. And Lockbox certainly still has a very high utilization rate amongst our member organizations. And then lastly, probably the lowest of the four, but self-service IVR. So patients call in and through phone voice prompts can make their payment over the phone 24/7 without ever talking to an actual representative. Although it is our lowest, we do find that it represents approximately 10% of the payments we're collecting. So it is still a viable source, and it doesn't appear to be going anywhere. And 10% of all payments that reduces a call to a specialist, again, just decreases cost to collect and improve the overall efficiency of the organization. And there's other payment platforms that are available above and beyond this that everyone, I think, is continuing to pursue and evaluate, whether it be PayPal, Apple Pay, really following the consumer markets and making sure that we give patients a number of different methods for which they can pay. And then the last pillar here would be the integrated payment engine, which none of this is patient-facing per se, but as we implement different pieces of technology through digital and print communication as well as payment sources, it's critical that all of those are talking to each other. The last thing we want to do is have all of these great communication tools and payment tools, and it creates patient frustration because they're not talking together. What I mean by that is if a patient calls and pays on the web or logs online and pays on the web portal, and we don't have that talking to our communication methods, the next thing you know, we drop a paper statement or send out a text message asking them, that their bill is overdue and when are they going to pay it. They're going to lose trust in that web portal and start to question where that payment went, results in a phone call to a specialist. And again, it just increases the touches that we have on that while sort of decreasing consumer confidence. So it's important that, all of our payment gateways talk to each other and reconcile, and we have our communication platform tied into that so that we're not releasing a statement the same day that a patient calls in or triggering an outbound call after a patient has already paid through electronic means. And it's just very critical to make sure that we think about all of those things as we implement new technology. So in summary, preparing for the future and just recapping the things we talked about today is continuing to evaluate and manage the impact of COVID-19. Hopefully that's less and less involving the ICU and actual care, but more so on the testing and vaccination side, continuing to reevaluate those processes and make them as efficient as possible, and preventing that lost revenue through those simple adjustments to the registration process, making sure that we're not lowering our registration standards in an effort to expedite the process, but critical to get that right up front so that we can receive the proper payment for all of those procedures. Continuing to leverage analytics and workflow technology to simplify denials management, not really necessarily related to COVID-19, but just revenue cycle processes 101 and making sure that we continue to evaluate new pieces of technology and how we can improve our workflow to make our representatives more successful following up on accounts. And then lastly, making it easier for patients to pay, our digital outbound communication, as well as our payment channels. That patient payment is really the last touch point they have with our healthcare organization. So they could have the best care in the world, but if they had a very poor experience on the back end and not understanding their statement, at the end of the day, most patients have a pretty wide choice of where they can choose to receive their health care. So it is critical that we do have an efficient and effective patient communication and payment platform. So our last poll question, how many of the revenue cycle improvement strategies discussed in our webinar are utilized at your hospital? Few, some, many, all, and other. All right, well, it looks like the majority are in the many category, which is great. Only one in the all, so it's reassuring for me that I didn't just waste everyone's time, but the some and many categories where we typically see people come in. Again, it's certainly not a all-encompassing presentation to address all the needs. We recognize that most organizations have little bits and pieces of everything, but how do we make it a well-rounded process and, add different tidbits of insight that could help each organization in a different way. So with that, we'll just wrap up with any questions that people may have. And thank you again for the time, and really enjoy doing these HFMA presentations. So certainly appreciate the opportunity.
Yeah, thanks, Jeremy, for presenting. We appreciate your expertise on it. For all the attendees on there, I'll give you a minute or two. If you want to throw any questions in the Q&A box, we'll hold on for a second and be happy to have Jeremy answer those for you. And again, in the meantime, if there are any questions coming through the Q&A box, we will grab those for you. But just a reminder, I will send out the link to the webinar recording and the continuing education form, as well as a survey for today's presentation on Friday at some point. And also, if you're interested in learning more or registering for these sessions, you can always check out the events calendar on the Georgia HFMA website as well. Jeremy, it looks like we had a question come through. Question was, what is the average return to normal operations time, like collecting copays and sending out statements?
Good question. It really varied among, our client set, and also as well as, where they were based at geographically, and, just how severe the pandemic was hitting certain areas of the country. I would say for the most part, we found that most of our organizations were back collecting copays and sending out statements in the May timeframe. The pause started in late March or April for those that did choose to halt sending out statements.
Excellent. Thanks, Jeremy. Well, for everyone else on the line, I don't want to hold you on the line. If you do have questions that were not answered, feel free to reply back to my email that's coming out on Friday. Again, this is Matt Fisher. I'll be sending out that information. And if you have any questions that didn't get answered, send those to me and I'll zip them over to Jeremy. And then make sure you get a reply on those as well. But again, Jeremy, thank you very much for your expertise and for your willingness to present. We're very grateful. For everyone on today's call, thank you very much for attending, and check out our events page for future webinars. At Georgia HFMA, we do a webinar every 2 weeks, always on Wednesdays. So check those out. Look and see what's coming up in the future. Thanks again, everybody. Actually, hang on, Jeremy, one more question came through. Have you found success in submitting medical records with claims?
Well, really only for the payers that allow it. We certainly do and continue to inquire with other payers, but as I'm sure most people are aware, most payers are pretty staunchly against it. So to the extent that we can, yes, and it is successful until we get our wrists slapped and we're no longer allowed to send them in advance. Excellent.
Well, thank you again, everybody. Look out for an email from me on Friday. I'll send out the presentation link, and so you can view the webinar at your leisure. It'll also be posted on Georgia HFMA's webpage under past events. So appreciate everybody's time. Happy Wednesday, and enjoy the rest of your day.
Great. Thank you.